Extract 1. Questions 1 to 12. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
You hear a doctor talking to a patient.
Hello, doctor. Good morning.
Good morning. May I find out what the problem is?
I've been experiencing the symptoms of heart failure for the past year, doctor. Although it appears okay in general, I feel a lot of stress and fatigue. I've also noticed shortness of breath with exertion. I am getting attacks of severe shortness of breath and coughing that usually occurs while I'm sleeping. I have developed edema and had a mild leg swelling a while ago.
Do you have severe chest pain called angina, palpitations, or syncope?
No, doctor, but I feel some irregularity in my pulse. Over the past 10 months, these symptoms have been gradually worsening. Over the past year, I've gained about 20 kilograms in weight, doctor.
What's your age?
63, doctor.
Have you had any previous illnesses?
I had right inguinal hernia surgery 7 years ago. I had trauma to my right thumb.
Do you have diabetes, mellitus, or heart murmur?
No, doctor.
Do you smoke or drink?
I don't smoke, but I drink.
Tell me about your family history. Any illness?
My mother's alive at 92. My father died at 76 of a heart attack.
Are you taking any medications?
Yes, doctor. Aspirin, 81 milligrams daily, and chlordiazepoxide and clidinium combination pill at 5 milligrams or 2.5 milligrams, 1 tablet daily for stress.
Are you allergic to any medicines?
No, doctor.
Okay, well, according to my comprehensive cardiovascular examination, your blood pressure is 120/70 in each arm seated. Your pulse is 80 beats per minute and regular. Your breathing is 2 times per minute, and that is unlabored. Lungs are clear to auscultation and percussion. The first and second heart sounds are normal. You have a fourth heart sound and a soft systolic murmur. The precordial impulse is enlarged. Your electrocardiogram shows sinus rhythm with left ventricle hypertrophy. Your peak oxygen consumption was 19.7 milliliters per kilogram of body mass per minute, which is consistent with mild cardiopulmonary disease. Laboratory data shows your thyroid stimulating hormone 1.33. Your glucose is 97 and creatine 0.9. Potassium is 4.3. I reviewed your echocardiogram thoroughly. That shows a dilated cardiomyopathy with ejection fraction of 15%. Your post-stress ejection fraction is 33%, and left ventricular cavity appears enlarged. This appears to be a newly diagnosed dilated cardiomyopathy of uncertain etiology and dyslipidemia. I'm going to prescribe angiotensin converting enzyme inhibitor lisinopril 2.5 milligrams daily and a beta blocker carvedilol 3.125 milligrams twice daily. In addition, you could benefit from a loop diuretic, furosemide 20 milligram daily. I don't think you need a defibrillator right now, and after 3 months of medication, I want you to go on an echocardiogram. If your left ventricular function has not improved, then you would benefit from a prophylactic use of an implantable cardioverter defibrillator. So continue with these medications and meet me after a period of 3 months.
Thank you, doctor.
Extract 2. Questions 13 to 24. You now have 30 seconds to look at the notes.
Good morning, doctor.
Good morning. Tell me about your problem.
I am having severe and recurrent jaw pain, doctor. There's also numbness and tingling along the jaw, teeth, and tongue.
How long have you had these problems?
For the past 6 months, I even consulted a dentist, but the dental evaluations are normal. I was also diagnosed with a throat infection last week, and I was prescribed Avalox, which I've almost completed. I am taking cough drops and trying to increase fluids.
Oh, I see. Do you drink or smoke?
No, doctor, but I used to chew tobacco for about 30 years, but I've recently stopped.
Okay.
Moreover, I've also lost the sensation of taste. The numbness is on the left lateral tongue and jaw that extends from the angle of the jaw to my lip, doctor. Recently, I've gained about 20 pounds of weight, and that may be due to decreased activity.
Do you get headaches?
Yes, doctor, about twice in a month.
Do you experience any fever or chills?
No, doctor.
Do you have any tooth pain, especially while biting?
No, doctor.
Have you had any jaw popping?
No, doctor.
Any spasm of the jaw that is trismus?
No, doctor. I've stopped chewing tobacco, and I'm using Nicorette gum now, doctor.
Okay. What's your age now?
50 years.
Have you ever had any surgery?
Yes, pertinent for hernia repair surgery.
What medications are you taking at the moment?
Tylenol, and I'm on Nicorette gum.
Are you allergic to any medicine?
Yes, I'm allergic to codeine. I used to feel dizzy or lightheaded when I took codeine.
Your blood pressure is 138/82, pulse 64 normal, temperature 98.3, and your weight is 191 pounds. Your oral cavity is normal with good moisture. You have a slightly decreased sensation to your left jaw that extends to the left lateral tongue and left intrabuccal mucosa. The fiber optic nasopharyngoscopy reveals a moderately deviated nasal septum to the left, large inferior terminates. You have developed persistent paresthesia of the left manual teeth and tongue, possibly neoplasm within the mandible. You have also developed hypogeusia with loss of taste and dry mouth syndrome called xerostomia. I would suggest you have a CT of your head, including sinuses and mandible, so that I can evaluate and make sure you have not developed neoplasm. Take plenty of fluids and come and see me again when you get your diagnosis reports.
That is the end of Part A. Now look at Part B. Now look at question 25. You hear a discussion between a physician and nurse explaining about schistosomiasis and its causes. Now read the question.
Hello, doctor. What is schistosomiasis, and what are its causes?
Schistosomiasis, also termed as bilharzia, is caused by parasitic worms. Although these worms are not found in the U.S., more than 200 million people are affected worldwide by this disease. In terms of impact, this disease stands next to malaria as the most devastating parasitic disease. Schistosomiasis is also considered one of the neglected tropical diseases. The parasites causing schistosomiasis dwell in certain types of freshwater snails. The infectious form of the parasite, known as Cercariae, emerge from the snail, therefore contaminating water. Most human infections are caused by Schistosoma mansoni, S. japonicum, or S. hematobium. One can become infected when the skin is exposed to contaminated fresh water.
Question 26. You hear a discussion between two doctors about the importance of measuring serum amylase or serum lipase. Now read the question.
Doctor, can you explain to me whether measuring serum amylase or serum lipase is significant for acute pancreatitis?
Well, measuring both serum lipase and serum amylase is not necessary. Measuring serum lipase alone is adequate for diagnosing acute pancreatitis, since it is more effective than serum amylase, especially because it rises more quickly and remains elevated longer. According to a study of 151 patients with acute pancreatitis, the sensitivity of lipase was about 97% and the specificity was almost 100%. Contrarily, the sensitivity of amylase was just 79% and the specificity was 99%. Therefore, amylase should be replaced by lipase as the first-line laboratory investigation for suspected acute pancreatitis.
Question 27. You hear a discussion between two doctors about the misdiagnosing of acute cardiorenal syndrome as renal injury due to hypovolemia. Now read the question.
Hello, doctor. What is your opinion about misdiagnosing of acute cardiorenal syndrome as renal injury due to hypovolemia?
Often, acute cardiorenal syndrome is misdiagnosed for renal injury due to hypovolemia. Patients with stable heart failure normally have mild hypervolemia at baseline. However, they can become hypovolemic due to severe diarrhea, over-aggressive diuretic therapy, or other causes. Although the fluid status of these two conditions are different, they are often difficult to distinguish. Urine electrolytes suggest a pre-renal acute kidney injury in both of these conditions. However, a history of recent diuretic overuse or recent fluid losses may help identify hypovolemia. If available, analyzing of the recent trend in weight will be essential in making the right diagnosis. Misdiagnosis of acute cardiorenal syndrome as hypovolemia-induced acute kidney injury will be catastrophic. In case the volume depletion in acute cardiorenal syndrome is erroneously judged to be the cause of acute renal injury. Therefore, fluid administration can further worsen both renal and cardiac function.
Question 28. You hear a physician explaining to his nurse about sepsis and infection. Now read the question.
Doctor, what is sepsis?
Sepsis is the extreme response from our body to an infection. This is a life-threatening condition, and without timely treatment, sepsis can rapidly cause tissue damage, organ failure, and mortality. This happens when an individual already has an infection in his lungs, skin, urinary tract, or somewhere else, triggering a chain reaction throughout the body. 4 types of infection that are often connected with sepsis are lungs, kidney, skin and gut, and the most frequently identified germs that cause infections and can develop into sepsis include Staphylococcus aureus or staph, Escherichia coli, and certain types of streptococcus. An infection occurs when germs enter into the body and multiply, causing illness, organ and tissue damage, or disease. In case that infection grows aggressively, resulting in a life-threatening condition, is called sepsis.
Question 29. You hear a discussion between two doctors about brain imaging prior to lumbar puncture in the suspected cases of bacterial meningitis. Now, read the question.
Hello, doctor. Can you please explain to me when the brain should start the imaging precede lumbar puncture in the suspected cases of bacterial meningitis?
For the patients with immunodeficiency or focal neurologic deficits, or with altered mental status or seizures in the past 7 days, a brain imaging should be performed prior to lumbar puncture. Moreover, corticosteroid therapy and empiric antibiotics should be started immediately after lumbar puncture without waiting for the results. Brain imaging should precede lumbar puncture in patients with focal neurologic deficits or immunodeficiency, or with altered mental status or seizures during the previous week. However, lumbar puncture can be safely done in most patients without first obtaining brain imaging. In case the lumbar puncture is to be delayed, then these treatments should be started immediately after obtaining the blood culture report.
Question 30. You hear a monologue by a physician about managing aneurysmal subarachnoid hemorrhage. Now, read the question.
Managing aneurysmal subarachnoid hemorrhage. Patients with aneurysmal subarachnoid hemorrhage are at high risk of complications such as delayed cerebral ischemia, rebleeding, cerebral infarction, and mortality. The main symptom is the abrupt onset of severe headaches. When this condition is suspected, a tomography without contrast should be performed. However, positive outcomes are seen when patients are managed in a high-volume center with a specialized neurointensive care unit. Early aneurysm repair by surgical clipping or endovascular coiling is the best strategy to reduce the risk of rebleeding. Medical and neurologic complications such as increased intracranial pressure, hydrocephalus, seizures, hyponatremia, delayed cerebral ischemia, hypovolemia, and cardiac and pulmonary abnormalities are extremely common.
This is the end of Part B. Now, look at Part C. You hear the doctor's lecture on acute cardiorenal syndrome. You have 90 seconds to read questions 31 to 36.
Cardiac and renal function are intricately interdependent, and failure of either of these organs causes injury to the other organ in a vicious cycle of worsening function. We are going to discuss about the acute exacerbation of heart failure or acute cardiorenal syndrome resulting in acute kidney injury, which is a common cause of admission to the intensive care unit. Let us examine the clinical definition, pathophysiology, hemodynamic derangements, clues that help in diagnosing and treatment. Cardiorenal syndromes are a group of interconnected disorders involving the heart and kidneys, which are classified based on whether the problem is acute or chronic, and whether the primary problem is in the heart, called cardiorenal syndrome, the kidneys, called renocardiac syndrome, or another organ, called secondary cardiorenal syndrome. Although the above definitions provide a good general description, there is a necessity of further clarification of the nature of organ dysfunction. Acute renal dysfunction can be unambiguously defined using an akin and rifle classification. Here, akin means acute kidney injury network, and rifle means risk, injury, failure, loss of kidney function, and end-stage kidney disease. On the other hand, acute cardiac dysfunction is an ambiguous term that includes pathophysiologically and clinically distinct conditions. Acute heart failure and cardiogenic shock. Cardiogenic shock is characterized by an abrupt compromise in cardiac pump functioning, resulting in global hypoperfusion that is severe enough to cause systemic organ damage. On the other hand, acute heart failure is defined as gradually or rapidly worsening symptoms and signs of congestive heart failure due to worsening pulmonary or systemic congestion. Hypervolemia is the hallmark of acute heart failure, whereas patients with cardiogenic shock may be hypovolemic or normovolemic. Although cardiac output may be mildly decreased in certain cases of acute heart failure, systemic perfusion is adequate to maintain the organ functioning. However, these two conditions cause renal injury by distinct mechanisms and have entirely different therapeutic implications. Reduced renal perfusion because of renal venous congestion is now considered as the major hemodynamic mechanism of renal injury in acute heart failure. On the other hand, in cardiogenic shock, renal perfusion is reduced due to a critical decrease of cardiac pump function. Therefore, the ideal definition of acute cardiorenal syndrome should describe a distinct pathophysiology of the syndrome and provide distinct therapeutic options that can counteract. Hence, we suggest that renal injury due to cardiogenic shock should not be included in its definition. So, discussion of acute cardiorenal syndrome is limited to renal injury caused by acute heart failure. Multiple mechanisms have been implicated in the pathophysiology of cardiorenal syndrome. Sympathetic hyperactivity is a compensatory mechanism in heart failure and may be aggravated in case cardiac output is further decreased. Its effects include constriction of afferent and efferent arterioles, causing decreased renal perfusion and increased tubular sodium and water reabsorption. Different strategies can be followed to prevent acute cardiorenal syndrome. An optimal outpatient diuretic regimen to avoid hypervolemia is very critical. Patients with advanced congestive heart failure should be monitored thoroughly in dedicated heart failure clinics until their diuretic regimen is optimized. Patients should be advised to get their weight checked periodically and seek medical opinion if they observe any increase in their weight or a decrease in their urine output.
Extract 2. Questions 37 to 42. You hear the doctor giving a lecture on anticoagulation therapy for patients with endocarditis. You have 90 seconds to read questions 37 to 42.
Hello, doctor. Can the patients with endocarditis be safely anticoagulated?
Managing anticoagulation in patients with endocarditis needs a personalized approach, using a careful risk-benefit evaluation on a case-by-case basis. There is a lack of high-quality evidence. Therefore, the recommendations also vary according to the clinical condition. Newly diagnosed native valve with endocarditis itself is not an indication of anticoagulation. The question of anticoagulation arises in patients who have a pre-existing or coexisting indication for anticoagulation, such as deep vein thrombosis, atrial fibrillation, pulmonary embolism, or an artificial prosthetic heart valve. The question becomes yet more complex in patients with cerebrovascular complications and a coexistent strong indication for anticoagulation. Earlier studies have suggested a significant risk of cerebral hemorrhage with anticoagulation in patients with native valve endocarditis. Consequently, some experts have expressed skepticism about these findings. Moreover, this skepticism arises from the studies that showed a lower incidence of cerebrovascular complications and smaller vegetation size in patients with prosthetic valve with endocarditis, in which most of the patients received anticoagulation therapy. The mechanism responsible for this effect is considered that the vegetation is an amalgam of destroyed cells, fibrin, and platelets, with anticoagulation preventing the growth and propagation of this aggregation. Some experts are of the view that the incidence of ischemic stroke with hemorrhagic transformation in patients with endocarditis receiving anticoagulation is overestimated. According to this concept, the beneficial effects at least counterbalance the harmful effects of anticoagulation. Moreover, the recent studies have shown that patients on anticoagulation tend to have fewer cerebrovascular complications and smaller vegetations. The studies reveal that not only are the cerebrovascular complications less common in patients who were already on anticoagulation when endocarditis was diagnosed, but also there was no increase in the rate of hemorrhagic lesions. These were all non-randomized studies, and most of the patients had native valve with endocarditis diagnosed at an early stage. Significantly, these studies revealed that there were only beneficial effects of anticoagulation if the patient was receiving warfarin before the diagnosis of endocarditis and initiation of antibiotic therapy. No benefits from anticoagulation were seen once antimicrobial therapy had begun. Therefore, starting anticoagulation and antiplatelet therapy for the sole purpose of stroke prevention is not advised for the patients with newly diagnosed endocarditis. For most of the patients with endocarditis and stroke or suspected stroke, anticoagulation and antiplatelet therapy should be temporarily discontinued. This is a need of careful evaluation, individualized assessment of the patients and the risk factors predisposing the patients to cerebrovascular complications, such as large vegetations or very mobile vegetations, or causative pathogens such as Candida spp or S. aureus. Therefore, may prompt temporary suspension of antiplatelet and anticoagulation therapy. In case there is a clear pre-existing or coexisting indication for these agents and surgery is not expected, consider continuing anticoagulant and antiplatelet therapy, providing that patients are free from the risk factors described above and suspicion of stroke has been excluded. In case surgery is considered for the patients with a clear pre-existing or coexisting indication for these agents, then a short-acting anticoagulant such as intravenous or low molecular weight heparin can be given as a bridge to surgery.